So today I've got a patient that just presented with me, and he's given me permission to describe what we've done. This particular patient showed up with a new complaint of vertigo. His symptoms are relatively fleeting. They disappear within 30 seconds. They typically occur when he rolls over in bed. They do not occur during the day when he's changing positions or postures. As I said, the symptoms typically are fleeting. They are resolved within about 30 seconds or so. And we're going to do a quick, we've already gone through the Epley maneuver, and he had a successful resolution of his vertigo symptoms. I just wanted to describe the process of what we're doing and how and why. So we've got feedback systems in the cervical spine to help feed forward to the brain and tell our brain where the head is in space. We want to rule those out first, so I'm going to use the swivel test. He's seated on a swivel chair. I'm going to have him face forward and keep his eyes on a single spot forward while I hold the head still, and he walks his body to the left as far as he can until you feel good tension in the cervical spine. We're going to stay here for about 30 seconds. Now, we've already done this, so I'm not going to stay here for 30 seconds, but we're looking for reproduction of symptoms. Now walk to the other side. And we'll repeat it here as well. Make sure you get all the way to the end of rotation there so you can feel the neck come into full rotation. And we look for any reproduction of symptoms. We do not have any reproduction of symptoms?
No.
Okay, go back to center. And while he sets himself up on the bench, I'll talk a little bit to the camera. Mm-hmm. If you'll go lay on your back, please. Mm-hmm. So the things that we're looking for with that rotation, as the cervical spine comes to tension and all of those mechanoreceptors are feeding forward to the brain, if the issue is mostly a cervicogenic vertigo, then we're going to wind up having a reproduction of the symptoms. If that is the case, then that's a point where we might want to do a little bit of manual therapy and possibly mobilization or manipulation in the cervical spine. This particular patient has already been screened for other red flags. He does have a prior history of cardiovascular disease, which he has been wonderfully controlling for the better part of how many years? 20?
No, it was
15?
Like, well, yeah, 2010.
Yeah.
Yeah,
So 12 years now, he has been incredibly well managed with those items. So we're feeling comfortable that we have a benign paroxysmal positional vertigo based on his symptom presentation so far. Now we're going to set him up for the Epley maneuver. But first, we need to figure out which side is problematic, and we'd like to do the best that we can, albeit it's not a great test, to make sure that we don't have any occlusive process in the arteries in the neck. So we're going to go over and do the Dix-Hallpike maneuver. For that, I'm going to have my patient scoot all the way to where his shoulders are just over the edge of the bench, and I'm going to slowly take him down and turn his head to the left to start with, and I'm going to instruct him to find something with his eyes and focus on it. This was his provocation before. I'm looking for nystagmus. Are you having any symptoms?
No.
He replies negative, and I am not seeing any nystagmus. Previously, we could see just a hint of nystagmus. We'd stay here for about 30 seconds on the Dix-Hallpike, and then we'd move him to the other side and do the same thing. Carefully watching the eyes, looking for nystagmus, and we don't see it. Now, it's not uncommon for your patient to feel nauseous and perhaps even vomitous in this particular procedure. So it's good to have a little something handy just in case things go south or head north, as it were. So previously, when we had this patient do this, his symptoms were reproduced with his head turned to the left. That would suggest that the labyrinth on the left side is the one that's affected. So we're going to position him to lay him onto his left side. So sit up, please. Drop your legs off of the left side of the bench. We've strategically gone from down to up. Now his butt is in exactly the right position so that when we lay him down, his head is dropped off of the bench. Now, I'm going to first have you to keep your head exactly where it is and lay on your side. Bring your legs right up onto the bench. I'm going to drop his head down so he is an effective, near pure left lateral flexion. We evaluate for symptom provocation. I'm watching the eyes. I see just a touch of nystagmus. Are you having any symptoms?
During the last maneuver down and when I was just up, I had very slight, very slight.
Just very slight symptoms. So it's not uncommon that after you do this, it's going to take a few more repetitions. The evidence would suggest that 2 repetitions with this will take care of about 85% of people. We did 2 repetitions before, and he had no symptom provocation on the second time around. So this time, this is what I'm sending him home with, this video, so that he can actually use this at home for follow-up. We're gonna stay about 30 seconds in that position. Now the head does not move. I want you to roll onto your back. Keeping a close eye on things here. We want to make sure that he's not going to roll off of the bench. The head stays where it is. And he's onto his back. We check for symptom provocation. I do not see any nystagmus this time. You okay?
Yes.
Okay. The other thing that I'm looking for here, if he's or I let him know, is if he's having symptoms, or if he feels symptoms, he needs to have a control mechanism, some agency to help himself with his symptoms. The way that you take care of that is to instruct him to focus his eyes on something in the near distance, and if he feels his symptoms, to keep his eyes open and really focus on that area. Okay? Now we're going to rotate the head alone slowly to the opposite side. In this case, we move from left to right. We evaluate for symptom provocation. I'm evaluating for objectively nystagmus. I don't see it. Now we look subjectively. Do you feel symptoms?
No.
The answer's negative. So we can progress a little quicker. We don't have to spend 30 seconds in each one of these positions if the symptom provocation is not there. Now, keeping the head where it is, roll up onto your right shoulder. The head stays down in effective right lateral flexion of the neck. No symptom provocation?
No.
Our next movement is the one that usually will bring on the symptoms the most strongly. So again, this needs to be handy if necessary. I'm going to coach him that on 3, we're going to sit up. So I want him to pre-position himself with 90 degrees of hip flexion and 90 degrees of knee flexion. He's going to push off of the bench with his right arm, and I'm going to assist him. We're going to count to 3 and sit up straight. 1, 2, 3. We look for symptom provocation. Are you feeling any symptoms?
No.
We were ready. We don't need it. And there is an Epley maneuver and an assessment protocol for benign paroxysmal positional vertigo versus vascular occlusion and versus other red flag nefarious things.
Thanks, it works.